I'd like to welcome everyone to our presentation today. This is an update on lung cancer screening. Some new guidelines have been released lately, and the North Carolina Lung Cancer Initiative has been kind enough to provide us with Dr. Mark Bowling to talk about these guidelines. You are all on mute, and we will entertain questions at the end of the presentation if there are any. You may also type your questions into the chat box at any time during the presentation, and unless it's a hair on fire, we will hold those until the end for Dr. Bowling to answer. So at this point, I'd like to turn the presentation over to Dr. Bowling with thanks for him presenting to us today.
No, thank you. My name is Mark Bowling. I'm one of the pulmonary critical care physicians at East Carolina University in Greenville, North Carolina. And I want to talk to you a little bit today about some updates with lung cancer screening, which hopefully all the centers out there are engaged in this, since it's a very important endeavor. So just for disclosures, I am a paid consultant for medical, Medtronic Surgical Solutions, Genentech Pharmaceuticals, as well as Biodesics. I'm not going to be speaking at all on any topic that will impinge upon any of these particular conflicts of interest. Objectives you can see here, we'll explore some evidence for lung cancer screening, and then look at methods for lung cancer screening, and then more importantly, kind of go over some of the CMS requirements, which might not be that obvious to folks. There's a lot of things that they actually demand that you have to have in orders as well as in notes that might not be that clear cut. Everybody knows the hard facts of lung cancer. It's the leading cause of cancer death. About 150,000 people died in 2016, and you can see over 200,000 new cases. And it kills more people than colon, breast, pancreas, and prostate combined, which is always a striking statistic to me. In North Carolina, about 19,000 people died from cancer. If you look at lung cancer death, it's about close to 5,700. You can see the numbers down there. If you take colorectal, prostate, breast, pancreas, and leukemia, that's about how much it takes to equal the amount of lung cancer deaths. And we hear these statistics all the time, but what does it really mean, and how can we put it in terms that we'll all understand? This is a 747 airplane. We're all familiar with this. It carries about 480 passengers. So in order to equal the amount of deaths that happened in North Carolina for lung cancer, that would be a 747 crashing once a month. So just think about that. A 747 crashing once a month. And that'll equal the number of lung cancer deaths that happen in a year in North Carolina. If you want to take that nationally, that's one per day nationally. Now, if you think about the news coverage whenever there's a plane crash, which is terrible, and it's a tragedy, but there is a plane, a 747, crashing every month in North Carolina, and it's from lung cancer. So just think about that impact. Why does this happen? A lot of it has to go with what we call the blame, shame, and despair. That, you know, these patients are smokers, is what a lot of folks say, and that, you know, if you smoke, you're going to be at risk for it, and that's certainly true. But we also know that there are a lot of non-smokers who have it as well. The other thing is the amount of research that goes into it. This is a graph actually looking at the number of deaths related to lung cancer, related to research dollars, and you can see that there's a lot more death and very little research put into lung cancer as compared to the other disease processes which you see related to colorectal, breast, or prostate. Why is that? Again, it's not just smokers. If you look in never smokers, lung cancer is the sixth leading cause of cancer death, and this primarily seems to be in young women or in women that have never smoked, and we're seeing an increased number of this. And like I tell everybody else, it's not everyone who smokes. This is Keisha and Chris Draft. Keisha Draft's a very beautiful woman. She was a cheerleader for the Charlotte Hornets. She also was a chemical engineer and was a drug rep. She married Chris Draft, who is a 13-year veteran of the NFL, and they got married right when he retired. If you've ever had the opportunity to hear him speak, you need to hear it. There's nothing else like it. He tells the story that they got engaged, was getting ready to get married, and all of a sudden she developed a cough that wouldn't go away. This is a very active woman, obviously, went to the doctor, and she had stage 4 adenocarcinoma. You can see the picture over there where it says Miss Draft. That's within a month after they had got engaged, and that was at her wedding. You can see the difference after she started therapy. She actually had to get special therapy to her back so she could stand up and dance at her wedding, and she passed away fairly quickly after she was married. Tell that to Taylor Bell Duck, too. This is one of our North Carolina natives who actually was an ECU soccer player, and during her freshman year started having trouble breathing, making her times during her workouts. And she also had a cough. It took almost a year for her to be diagnosed, but she wound up having lung cancer, so never smoker as well. So it does happen to those who don't smoke. As far as the mortality for lung cancer, we all know they're dismal numbers, and the earlier you catch it, the better. And we always are huge advocates for ablative therapies, which primarily is going to be surgery if at all possible. I think these numbers are changing as therapy gets better, but the whole goal about this is to try to catch cancer as soon as possible. Most people present with lung cancer in the latter stages, as you see, because that's when they become symptomatic. So if we can catch it in early stages, that's the best, and that's where screening comes in. So the goal of screening is to increase the overall cure rate and to increase limited surgical resection and decrease mortality and morbidity. What happens if you don't treat stage 1 or 2 lung cancer? This is some data that came from a gentleman named Detterbeck. It used to be at University of North Carolina. I believe now is up at Brigham's. But if you don't treat stage 1 and stage 2, 98% 5-year mortality. If they're non-treated. The median survival was 10 months. So early stage lung cancer does not stay early stage for long. And to that patient, a pulmonary nodule it can be an emergency. It's a very unnerving thing. There's been lots of studies to look at how are we going to screen. There's been chest X-ray and sputum studies, and you can see there was 4 controlled trials, and there's also there's CT scans of the chest. There were 6 single center trials. There was a lot of issues with a lot of these trials. What was basically found in all of them is that we were able to identify more cancer, but there wasn't a mortality difference. One of the big studies was the ECLAP study that basically showed that by screening these patients and getting them to surgery very quick, you could see there was a much better survival rate, over 80%. And this was almost 20 years ago, and we knew that lung cancer screening was going to make a difference at that time. But it really wasn't until the National Lung Cancer Screening Trial, which is New England Journal of Medicine in 2011, that really made the difference. It showed a 20% reduction in mortality, and you can see a 6.7% reduction in all-cause mortality. And basically, the number needed to treat to prevent one cancer death was 320 CT scans, which is very important. So you saw one cancer in 320. Now compare that to mammograms and colonoscopy, you can see the difference there. This the NLST basically led to CMS evaluating whether or not it's feasible to pay for lung cancer screening. So then it went to the U.S. Preventative Task Force to evaluate this, which we all know pretty much gives recommendations that CMS and a lot of the other insurance companies will follow to say, based on evidence, whether or not it's beneficial to proceed with the screening process. In particular, they were looking at does this decrease mortality, and is there any harm in doing it? And the population, number one, had to be asymptomatic, and they used an age from 50 to 80 years and a greater than 30-pack year smoking history, or you had to have not been smoking any more than 15 years when you had stopped smoking. And what they came up with was a gray B. They thought it was a moderate net benefit, which means that they felt like there was more benefit than there was to potential harm based on the criteria of the age of 50 to 80 and the greater than 30-pack year smoking history. And they recommended an annual low-dose CT scan until either you're older than 80 or you've stopped smoking for greater than 15 years. And they also said if you have limits that will decrease your life expectancy, or you're not able to undergo therapy. Now, particularly for this particular trial, they mentioned surgery, but But I think there is an argument to be made that if patients did have a potentially resectable lung cancer but was unable to tolerate it due to poor lung function or some other health reasons, stereotactic body radiation therapy should really be considered there too, because that potentially could make a difference for that patient and has about an 80% cure rate. There are potential harms with screening. This is one of the big issues that was being evaluated when CMS was trying to decide to pay for this, as well as any other screening. And the complications of a diagnostic procedure and the National Lung Cancer Screen Trial was 33. And this is per 10,000 for CT scan versus 10 for a chest x-ray. If you look at overdiagnosis, which basically means that you are more likely to die with the cancer and not of the cancer, it's about similar to what we saw in chest x-ray, and most of it was related mostly to bronchoalveolar carcinoma, which is about 79%. And radiation exposure is one of the big things that folks worry about, and the participants in the National Lung Cancer Screening Trial had about 8 millisieverts per participant over 3 years, and that's roughly equals out to about 1 cancer death potentially could be related to radiation from imaging per about 2,500 persons screened. If you kind of break it down and think about the other modalities that we do, the low-dose CT scan, which is highlighted here, is about 1.5 millisieverts, and that's equal to about 6 months of background. So the risk of really having an issue with this is very low, and you can see that compared to chest x-ray and mammography. The worst or the highest risk is really the CT scan of the abdomen and pelvis, which you can see. So you're talking about 1 CT scan for a year, per year, until either the person has stopped smoking for greater than 15 years or they're outside the age limit. So screening in the Affordable Care Act, this might be up for debate. We're not sure what's going to happen, but as the law states right now, any private health care plans are required to cover any screening given an A or a B recommendation by a U.S. Preventative Task Force. And remember, the U.S. Preventative Task Force gave lung cancer screening a B. Now, notice this is health care plans, and it's private health care plans. And it also says there will be no deductibles or co-payments. It's also important to note that the requirements have to be the exact same that the U.S. Preventative Task Force recommended, not necessarily what CMS recommended, and I'll discuss that in a moment. And they also mention no deductibles or co-payments, and it does not specifically apply to Medicare, at least when this was initially written, because Medicare wasn't paying for it, and then fall of 2013, CMS had 2 requests for a national coverage decision. So that's a background, basically, really quickly, of lung cancer screening, but the nuts and bolts of it is now it's been approved for coverage by both private insurance and CMS. And basically the thing to remember is that screening is a process. It's not just a test. You have to have a really organized approach, and you have to have a multidisciplinary approach. And part of the CMS requirements are that you have an organized approach, and I'm going to discuss those in just a moment. In particular, you have to have nurse leaders and business administration and radiologists have to be involved, and primary care physicians, and then all of your folks that deal with cancer, your oncologists, both medical, radiation, pulmonologists should be involved, as well as surgeons. And the CMS requirements basically break it down into clinical requirements and radiologic requirements. And you can anticipate that there will be audits eventually on this, so getting all the documentation right is going to be very important, and a lot of folks might not really realize how much you actually have to document and where that documentation has to be in order to be compliant. So these are busy screens. I don't expect to go over all these. I basically put this in here and I'll just highlight it because I wanted folks to have it if they need it and they can refer back to it. But the radiologic requirements you can get right from the CMS document. You can see here, and there are certain requirements. You have to have board certified radiologists, you have to document the training, you have to see the different credentials that they have there, which you can see on the screen. The imaging facilities also have certain requirements they have to have, and again, you can see it's fairly involved. One of the big things I'll point out is you have to have a smoking cessation program for current smokers as part of this process. And then one other thing to point out, the reason why this is important is for multiple things, but also CMS has dictated and mandated actually that there has to be a national registry, and that national registry has to have certain requirements, which requirements I'm showing you now, and each center is responsible for putting data into that national registry. And there are various ones. The American College of Radiologists has one. That's the particular site that we use, and there's several bits of data that you have to put in there for CMS. What will happen is CMS has certified those particular databases and will have access to those databases at certain points. What you have to report, again, the requirements: you have to have a steering committee, you have to have a management plan and an operational plan, and then you have to have a mechanism to collect information, description of data management, and then use of CMS approved standardized data dictionary. And you can read this stuff, so it's fairly involved, but the bottom line with this is that you have to have eligibility for your radiologist, you have to have eligibility for the different machines that you use in the facilities, and then you have to have access to one of these databases that will be able to report to CMS. And this is just showing you the various things that have to be in there. This is the reportable data that you actually have to put in. I'm actually the person at our center that does this, believe it or not. And I have to put this data in myself into this database, and this is exactly, you have to have an identifier, MPI number, obviously a patient identifier, the ordering practitioner's MPI number, the model and make of the CT scanner, why the screen is being done. It's extremely important that you document those questions, that there's no signs or symptoms of lung cancer, which I'll talk about in a minute. You have to talk about the lung nodule identification and classification recording system, which is what's called LRADS. I'll talk about that in a minute. You have to document again, and what you'll see over and over again is a lot of these questions have to be documented in various places. The answers to them, so your smoking status, the person's age, all that stuff you'll see documented over and over again in various forms throughout this process. And then you have to actually put the radiation dose in there, because obviously CMS, once they gather lots of data, they're going to go back and look at this again. This is the identification of the reporting system that has been adopted pretty much by every organization and also by CMS, and it's basically just a way to report. It's a language that the radiologist can use to report the findings. And again, this is overall what it looks like. I don't expect you to be able to see that, but you could probably see this, and this is basically what it is we talk about lung RADS 1, 2, 3, 4A, and 4B, and then you can see the various breakdowns. And 90% of the folks that are screened will have a benign appearance or behavior or a negative scan. Very few will actually have abnormal findings. And then they give recommendations for the management based on those findings. If it's a lung RADS 3, for example, they'll recommend a 6-month follow-up low-dose CT scan. If it's a 4A, you can see the recommendations can be PET scan or CT scan, so forth and so on. And again, this is a way to be able to identify and follow. That there's issues and a lot of controversy with the way this is management. If you talk to a lot of radiologists, they'll tell you that using a low-dose CT scan to follow up a pulmonary nodule may not be the best. It doesn't give you a lot of the detail that you need. And then you have jumping straight to a PET CT scan instead of just you can either get a low-dose CT scan in 3 months or a PET CT scan. So I think some of this will need to be cleaned up in the future, but certainly the recommendations are there, and that's what you should follow. So the clinical requirements, there has to be a pre-screening visit, And then there's subsequent visits. And the pre-screening visit has to be done by a provider. And the provider is defined in the section that you see there in the Social Security Act as a physician, a nurse practitioner, a PA, or a nurse specialist. And the nurse specialist is defined basically from the way I understood it, and I read the document, as a nurse that has an advanced degree and focuses in a certain area, but doesn't necessarily have to have the advanced degree in that particular area of concentration. So for example, if you're a nurse with a master's degree in public health, for example, or in nursing or nursing administration, and you are a nurse navigator, that's all you really need, and you would be able to do these pre-screening visits and be able to bill for it. The biggest component of this is what they call a shared decision-making visit, and it should be probably part of your annual health maintenance evaluation. And what's important is you have to document in somewhere in the chart, it really should probably be in your progress note, the following. And everyone's going to know to document the big three, is what I call them, is your age. Do they have a 30-pack year smoking history? And if they stopped smoking, is it less than 15 years? The age that Medicare approves of is 55 to 77. Notice that the U.S. Preventative Health Task Force said 50 to 80. So private insurances will follow the U.S. Preventative Task Force 50 to 80. CMS, Medicare, will follow to 55 to 77. You have to document that. You have to document their smoking status. You also have to document in the progress notes that the patient has no symptoms of lung cancer. And this is one of the areas of confusion I get from a lot of folks who ask me, well, everybody's dyspneic because they have COPD. If they are short of breath and you put that down there, you have to say, as a physician seeing this patient, you don't think it's related to lung cancer. So remember, it's symptoms of lung cancer. Shortness of breath can be due to lung cancer. If you think their shortness of breath is due to lung cancer, then don't get a screening test. You would order a different test, like a CT scan or a regular x-ray. So it has to be an asymptomatic patient from lung cancer. You also have to document the risk and benefits of lung cancer in the progress note. That there are risks to doing it. For example, like overdiagnosis, radiation exposure, false positive results, doing more tests, and the fact that you could find lung cancer. Again, you have to document that you talk to the patient about these things. You don't have to necessarily list them all out, but you have to say that you have to talk to them about those aspects of their care. And then you also have to mention that you talk to the patient and stress the importance that they adhere to continued screening. So once they're in it, they need to continue to follow doing it. And you also have to document that they do not have any comorbidities that might prevent them from having therapy, and that they agree to proceed on with further evaluation if something's found. And this is right out of the CMS documents and what they're going to require that needs to be in the chart for this pre-screening visit. What we did at our institution is we took advantage, and this is just an example here that I made and use in our charts, and our primary care docs use it, is you can use a smart phrase or dictate something like this that goes over all, and it's almost like an attestation statement that said that you did this and you talked to them and they're in the right age and they've had a 30-pack year smoking history and they do not have any comorbidities, and you talk to them about all the risk associated with it and so forth and so on. And we've been using this now for about 2 years, and it seems to help quite a bit. Obviously, I tell every physician you need to do this, and you should somewhere in your conversation talk to the patient about it. And not just blindly put this in as just a template, because it is important that it is a shared decision. So that was the clinical aspect of actually seeing the patient. Now you have to put an order in, and the order also has to have certain criteria. The order has to have the patient's date of birth, which is pretty straightforward. Again, like I mentioned earlier, you have to put the number of pack years. You also have to put their current smoking status. Have they quit smoking or are they currently smoking? You also have to put a statement that they're asymptomatic, has to be in the order, and then you have to have the NPI of the ordering physician. The reason this is important because it goes back to that database, that all that information has to go into the database. So you can see there's a lot of redundancy here. But this is stuff you have to have in order to be compliant, and probably, more than likely, CMS will come in and evaluate to see if centers who are doing screening and then billing for the lung cancer screening, if they're meeting these requirements. These are just some of the codes you can use for lung cancer screening. I put these in here just for you to be able to have, and these are some of the things that we've been able to use for your shared decision making. Again, this is just more about the counseling visit and low-dose CT screening, just some codes. I get this quite a bit about what codes to use, so I wanted to give folks an example of how they could build a template for this. And then reimbursement. This just recently came through about in the last year, and you can see the reimbursement rates over here as far as the global payment and the counseling, and then as far as the low-dose screening visit. And that's a fairly quick summary. That's basically it. The thing to remember is that lung cancer is bad, and it's the leading cause of cancer death. And prevention is probably the best. Obviously, it's going to have a better impact on mortality than screening, but screening is going to be very important, and we really think it's going to save lives. This is just the bottom line that you got to remember, that there's pre-screening criteria and clinical criteria, and then there's your order has a certain order has to have a criteria, and you also have to have radiologic criteria. For the clinical pre-screening criteria, 55 to 77 for Medicare, 50 to 80 for private insurance. You have to have a 30-pack year or greater smoking history, and you have to have stopped smoking within 15 years. You have to be asymptomatic from lung cancer, and you got to document the risk and benefits discussed with the patient, that they're going to adhere to screening, that they have no severe comorbidities to prevent them from getting any further screening. This is a DOTS phrase that we had down there in our EHR. And then also you've got to talk about smoking cessation. Again, you've talked to them if they are smoking, about to stop smoking. And then for your order, you also have to have 55 to 77. You have to have their age, their smoking status again, if they're that they are asymptomatic, and then the NPI number of the physician ordering, which is all fairly easy. And you can build this into templates, and it can go fairly well. This is just some things that might help you. These are some websites that you can copy or use that can be some good resources for you. We're currently at our institution, we have 9 hospitals all in one system that are doing screening, and we've screened a little over 700 folks in about little over 2 years, and we found close to 30 cancers. And currently our ratio is 1 cancer for every 26 CT scans, and you saw the national average was 1 in 320. So it really can make a difference, and we're still, I think, just scratching the surface on that. Well, again, I want to thank everybody, and I'm happy to take any questions if anyone has any questions. And this has been a delight, something I really like to talk about. Hope that I've been able to help you.
Okay, thank you, Dr. Bowling. I really enjoyed that. It was really shocking to see the plane crash a day with lung cancer death. It's just incredible. I don't see any questions out there, and I don't see anybody typing frantically. So it looks like that we're good to go. I thank you very much for providing such a good summary and telling us about these guidelines and the morbidity that we could address by doing these screenings. So thanks very much, and again, thanks to the North Carolina Lung Cancer Initiative for providing you to us for this presentation. So at this time, we'll end the broadcast. Thanks very much to everyone.